times in the past, in which you can see that in addition to our own research efforts, multiple centers in the United States, in Europe, in Asia, and actually there's a recent South American study from Argentina coming out, and from Colombia as well, that are going to be showing the prevalence of MYD88 mutations in patients with Waldenstrom's at a high prevalent rate. The second group of mutations that we have identified is some mutations in the gene CXER4. Clinically speaking, those patients are the patients who tend to present with higher IgM levels. Those are the patients who tend to have more involvement in their bone marrows, more problems with hyperviscosity, as well as acquired clotting problems. And again, in the initial study reported by us at about 30% prevalent rate, other studies have shown similar findings from Europe and Asia as well. In a more recent study, we have up to 40% of our patients can have mutations in CXCR4. Now, this is an important aspect, not only because clinically speaking, we understand the disease a little bit better, but also because it's a target. You know, it's a target that we could potentially use to treat patients that we will see later on. So this is not to confuse people, but rather to let you understand how science impacts what we do. You know, this is the MYD88 signaling pathway on the left, the CXCR4 signaling pathway on the right, and then we have multiple steps in which these pathways can affect, or patients and affect the survival of these malignant cells. And all these steps do become a potential target. So BTK is an important aspect of things for targeting of the disease. PI3 kinase is another target. AKT is another target. And as we will see later on, how these can be targeted in different ways in a more elegant manner rather than doing a blunt treatment. We kind of pinpoint what we need to attack and understand it better so we can have more treatment options. So let's start with some Ibrutinib combinations. Ibrutinib is a BTK inhibitor. Ibrutinib is already approved by the FDA for the use in patients with Waldenstrom's since 2015. The combination of Ibrutinib and rituximab was approved by the FDA in 2018. So BTK inhibition is here to stay. And I'm gonna show you how are we rationally combining other agents with Ibrutinib to improve outcomes in patients with Waldenstrom's. So this is the first, one of the first studies. This is a study coming from Europe in which bendamustine and rituximab are being combined with Ibrutinib to treat patients with Waldenstrom's. This is a study that is ongoing. Bortezomib, this is not bendamustine, it's bortezomib. Bortezomib is given subcutaneously. Rituximab is also given subcutaneously, and Ibrutinib is given orally, as you can see here. So rituximab is given monthly. The initial is intravenous, and all the other ones are subcutaneous. This is monthly throughout 2 months of therapy. Bortezomib is given once a week, 3 weeks on, 1 week off, 6 cycles. And Ibrutinib is going to be given throughout treatment. So this is a 30-month study, 6 months of combination, and 2 years of Ibrutinib and rituximab alone. And the idea is to stop all treatments at that time and then see if that brings patients to the responses that we would like to have. The other one is a combination with carfilzomib. Carfilzomib is a second-generation proteasome inhibitor. Bortezomib, the main issue with it is neuropathy. Carfilzomib doesn't seem to have neuropathy. It does have other problems. There are some issues with lung and cardiac toxicity with carfilzomib, especially in elderly patients. But this is a study in which it's a randomization. Half of the group is going to be treated with Ibrutinib alone, and the other half of the group will be treated with carfilzomib and Ibrutinib, and we will see this combination. About 180 patients are aimed to be participating in the study. And as you can see here, it's going to be a 2-phase study, 12 months with carfilzomib weekly, and then 12 months of carfilzomib every other week. And Ibrutinib is given throughout on a daily basis for 24 months. And then carfilzomib will be stopped and Ibrutinib will continue indefinitely. We do not, all these studies are accruing patients at this time. They're not, we don't have any results on these studies yet. And then the third member of the family of proteasome inhibitors is this oral agent called ixazomib. And the Mayo Clinic and the National Cancer Institute are also running this study on ibrutinib and ixazomib combined. Again, this is a 2-year therapy. Ixazomib is given weekly, 3 weeks on, 1 week off for 24 months. Ibrutinib is given every day at 420 milligrams, which is the standard. And they will, after 2 years, ixazomib will be stopped and ibrutinib will be continued all the way to disease progression or unacceptable toxicity. The other agent that we have been really interested on is this agent called daratumumab. Daratumumab is an antibody very much like rituximab, but instead of attacking CD20, which is a very common marker in B cells, daratumumab targets CD38, which is a very common target in plasma cells that are the ones that produce the IgM. So there have been some laboratory data from the Mayo Clinic suggesting that the combination of ibrutinib and daratumumab is much more powerful than ibrutinib or daratumumab separate in killing cells, malignant cells in Waldenstrom patients. So this is a Cornell and Mayo Clinic study. 24 patients will be enrolled in this study. And two groups of people will be included, patients who have never gotten ibrutinib or patients who have been on ibrutinib and they have reached a plateau and for some reason they are not satisfied with that plateau. And then daratumumab will be added to see if the response can be deepened. So this is going to be an induction phase of 2 months with daratumumab weekly, and then a consolidation phase of 4 months with daratumumab every other week, and then a maintenance phase of 18 months with daratumumab monthly for a total of 2 years of therapy of daratumumab. Ibrutinib will be studied right from the get-go and will continue at 420 milligrams all the way to an acceptable toxicity or disease progression. So this is also an ongoing study in the United States. Now, there is a new group of Btk inhibitors. There is a number of them that are being developed, and not only for Waldenstrom, but also for similar conditions that respond to Btk inhibitors, such as chronic lymphocytic leukemia or CLL, or even for marginal zone lymphoma or MZL. So we're going to be talking about these new Btk inhibitors next. The one that has already been published in January of this year is Calabrutinib. Calabrutinib is supposedly a Btk inhibitor that is more specific to Btk than ibrutinib is. And in this study, about 100 and some patients were exposed, patients with Waldenstrom's. About a dozen of patients were never treated, and about 90 some patients were previously treated. And as you can see here on the left, how the major response rates are of over 80% in both groups. Interestingly enough, when we think about MYD88 mutated and MYD88 wild type patients, we also saw some responses in wild type patients, suggesting that Calabrutinib may be effective in that group of patients. As you have heard Steve and I talking about MYD88 testing, the devil is in the details, and sometimes what other groups of research groups label as a MYD88 wild type patient might not apply precisely to what we mean as a wild type patient, just because most studies evaluate the sensitivity of MYD88 about 1 in 100, which is really good, but our laboratory goes to about 1 in 1,000. So we do have a number of patients who are labeled as MYD88 wild type outside of the Dana-Farber, and when they come to see us, ended up that they had the mutation all along. So we need to be very careful about these MYD88 results, and the group is very small as well. But maybe there's an indication that even the MYD88 wild type patients might benefit from Btk inhibitors, depending on who is doing the testing. Now, Calabrutinib will be added to the National Comprehensive Cancer Network guidelines. Those are the American guidelines that support therapies in patients with different malignancies. And so will be available commercially for patients with Waldenstrom's later this year. Here we have the progression-free survival, how long it takes for patients to progress. And we can see here that at 2 years, anywhere between 80 and 90% of patients continue without evidence of progression, which is highly interesting. Then the toxicity is very similar to ibrutinib in terms of the bleeding and the rash and the gastrointestinal symptoms and things like that. Even some atrial fibrillation is also seen with Calabrutinib, about 5 to 6%. So it's not dramatically reduced compared to Ibrutinib. But again, another option. This is taken twice a day, one pill twice a day, compared to Ibrutinib that is taken once daily. The other agent that is up and coming is this agent coming from China called Zanubrutinib. They went big. They went big because they really went for a study comparing against Ibrutinib. The prior study of Calabrutinib is just single arm. There was no comparators. Here in this study, there were two groups, the Zanubrutinib arm and the Ibrutinib arm randomized. So that's a very interesting approach. And also they did a separate study only for MYD88 negative patients, as you can see there, arm C. So that's what we call the ASPEN study. A number of different centers in the world have participated in this study. And now some of the results are out. These were presented fairly recently at the ASCO meeting in Chicago. Well, it was virtual, but it's supposedly to have been in Chicago this past June. And we can see here that Ibrutinib and Zanubrutinib have very similar major response rates at about 78 and 77% respectively. When you look at the VGPR rate, which is a very good partial response rate, it was 19% for Ibrutinib and 28% for Zanu. So very, very minor superiority maybe of Zanubrutinib, but this was not enough to get them, you know, what we call superiority per se. You know, there was not a big of a difference enough. In any case, the interesting part of all this, it looks like efficacy and everything else seems to be very similar, but the atrial fibrillation arm on Zanubrutinib was 2% versus 15% of Ibrutinib. So if anything, the main benefit of Zanubrutinib will be to actually be associated with a lower risk of atrial fibrillation compared to Ibrutinib. And that is something that, you know, I think could be potentially clinically relevant. We are discussing at the National Cancer Network currently the addition of Zanubrutinib for patients with Waldenström. So my sense is this will be an option for therapies later this year or very early next year. So this is for patients without MYD88 mutations. And again, I want to be very emphatic of what MYD88, you know, wild type means for institutions outside of the outside of the Dana-Farber. Here we have that the genomic testing was done by this company called NeoGenomics, which is really good and respectable. But again, their sensitivity is 1 in 100 compared to 1 in 1,000 at Dana-Farber. So based on these factors, even if you were MYD88 wild type, 50% of patients achieved a major response with Zanubrutinib, with about 27% actually getting to a VGPR with Zanubrutinib. This also was presented at ASCO. And I think it provides additional evidence that patients with these new Btk inhibitors, you know, might benefit, even MYD88 wild type patients might benefit from these treatments. The adverse events are very similar as well to Ibrutinib, with the main difference that hypertension and atrial fibrillation rates seem to be lower. Now we have new Btk inhibitors. And why do we need new Btk inhibitors? It's because all these agents that I just talked about, Ibrutinib, Calabrutinib, and Zanubrutinib, are what we call covalent Btk inhibitors. So they bind to BTK in a very specific manner. And the problem is some patients develop mutations against these BTK inhibitors, specifically a mutation on the BTK gene in a molecule called C481S. So when that happens, these BTK inhibitors, Ibrutinib, Acala, and Zanu, cannot bind to BTK anymore. So what has happened is they have developed new BTK inhibitors that bind to BTK in a different way. So they do not require 481 to be attached to it. And therefore, even if patients were to have that mutation, these new BTK inhibitors might actually be effective. So there are 3 in the market that are being developed in clinical trials. I'm going to show you some preliminary results of these. One of them is called Venetoclax. These data were presented at ASH last year by John Allen at Cornell. 27 patients so far. They were increasing the doses from 25 to 50 to 100. They were up to 300 milligrams. And initially it was some excitement. Having said that, I think it was like 2 or 3 weeks ago, that the manufacturers of Calabrutinib have dropped it off. They said that they do not believe they will continue the development of this agent as they are not seeing the efficacy they thought they were going to see. So this seems not to be a runner in the race anymore. The other medication that is very much up and running is LOXO-305. Is also a non-covalent Btk inhibitor. It is also oral. This is data from ASH last year, presented by Anthony Mato at the University of Pennsylvania, 13 patients. No Waldenstrom patients were here, but we have this study open currently at Dana-Farber. It is accepting patients with Waldenstrom's who have been exposed to Ibrutinib, who have been progressed on Ibrutinib or are intolerant to Ibrutinib. So, so far, we do have some data. This data is not included here, but confidentially, there have been at least a dozen of patients with Waldenstrom's have been exposed to LOXO-305, and there have been some responses, even in patients who have been resistant to Ibrutinib previously. So that is an encouraging molecule that is definitely continue development clinically. The other agent is ARQ-531, very similar situation, also being tried in CLL and other conditions, now including Waldenstrom patients. This is data presented last year by Jennifer Wojcik at Ohio State. I think Ohio State and Mayo Clinic have this study open, the ARQ-531. I don't think we have it done open at Dana-Farber, but definitely another very exciting agent that could potentially be effective even in patients who have progressed on Ibrutinib. Now, CXER4 becomes a target. You know, not only was a development in terms of the understanding of the biology of the disease, but now becomes a target. And what prompted our interest was the fact that when patients with Waldenstrom's with CXER4 mutations get exposed to Ibrutinib, they do benefit, but they do benefit just a touch better, a touch less, right? So 100% of patients respond when they don't have CXER4 mutations. About 86% of patients respond with CXER4 mutations, just a little bit lower. 97% had major responses without CXER4. With CXER4, 67%, just a little bit lower. In VGPRs, 40% without CXER4, 10% with CXER4. So not that Ibrutinib is not effective in CXER4 mutated patients, but is just a touch less effective compared to patients without CXER4 mutations. And not only that, when we look also at the progression-free survival, we see that about half of the patients with CXER4 mutations had progressed at about 4 years of therapy, while 75% of patients without CXER4 mutations have not yet progressed at 5 years of treatment. So there are differences also in how durable the response is, not only how deep the response is. So one of the initial efforts that we run was adding an anti-CXER4 antibody called ulocuplimab to Ibrutinib. This is the design of that study. Ibrutinib is given indefinitely, and ulocuplimab was given weekly for the first 4 weeks, and then every other week for 20 weeks for a total of 6 months. And then patients continue on Ibrutinib on its own. So these data, I think, will probably be presented later this year by Stephen Trion. So I'm not gonna steal his thunder. I'm gonna let him present this data to you. All I can say is it looks very positive. And now the next study that we just opened at Dana-Farber and other places as well is there is an oral agent, a pill from treatment against CXER4 called mavorixafor. So in this study, Ibrutinib is being combined with mavorixafor and being given to patients. The combination will be given indefinitely. So about 18 participants are being enrolled. I think the Colorado Cancer Center with Dr. Matos is already accruing patients. They have opened 2 or 3 other sites in Europe as well, including Greece, and I think Germany or Spain, if I'm not mistaken. So mavorixafor starts at 200 milligrams per day for, I think it's about a month, and then 400 for a month, and then 600 indefinitely. Ibrutinib is given over 2 years, and then both continue indefinitely from then on. So I think we will be very excited on seeing what the efficacy of this combination is, specifically in patients who have CXER4 mutations. Now, this is, I think, is going to be of interest because we know that CXER4, even though it's not mutated, is overexpressed in Waldenstrom's as well as other malignancies. So I think this mavorixafor has the potential of also affecting, favorably other cancers without CXER4 mutations, but with CXER4 overexpression. I think the last part is going to be BCL2 inhibitors. We are very excited about this. This is an agent called Venetoclax that you will see pretty much everywhere very, very shortly. The reason for that is because BCL2 is a pathway that is overexpressed in over 75% of human cancers, not only in blood cancers, but also in solid cancers. And there are going to be a lot of studies in breast, in colon, in prostate, and whatever you can imagine. But it all started with blood cancers. So Venetoclax is already approved for CLL and in acute leukemias as well. So this is preliminary data from our study in Waldenstrom's that we presented last year at the myeloma workshop. 31 patients were included. All of them had MYD88 mutations, about half had CXER4 mutations. And we studied at 100 milligrams or 200 milligrams daily for a week, then 400 for a week, and then 800 milligrams for 2 years of therapy. And then the interesting part here is all the patients stopped therapy at 2 years. So this is not an indefinite duration treatment. So the preliminarily speaking, what we have here is the results based on the response. The longer the bar, the deeper the response is. And the color depends on which mutations patients have. If it's red, then patients had CXER4 mutations. If it's gray, the patients did not have CXER4 mutations. And as you can see here, if we draw a line at 25, in between 20 and 30, which is the minor responses, you can see that over 90% of patients actually responded. If you throw a line about 50%, which is major responses, you can see that about 80% of patients responded. And if you throw a line at 90%, which is the VGPR rate, you can see that about 20% of patients got into a VGPR on Venetoclax. About half of these patients were previously exposed to Ibrutinib. So this is a medication that could work even if Ibrutinib fails. And now, where we see an actual difference is if you were previously exposed to Ibrutinib, the orange lines compared to the blue lines, you can see how the orange lines are more in the superficial side, while the blue lines are more in the deeper side. It looks like prior exposure to Ibrutinib might actually blunt the response to Venetoclax a little bit. But again, the study was halfway at this time. We are actually working on a more advanced report now that all the patients have completed treatments. So we will be hearing about this probably later this year a little bit more. This is the progression-free survival, about 75% at 2 years, which is very encouraging. And obviously what we need to know is what happens when the patients stop therapy, right? So we will be showing that later on this year. The main side effects are neutropenia, which is low white blood cell counts. None of the patients had a high rate of infections. None of these patients had actual fevers or admissions to the hospital because of this. So this seems to be more of a number issue, much more than an actual clinical relevance, but something to have in mind. So these results were so encouraging that we are currently running a clinical trial combining Ibrutinib and Venetoclax in patients who have not been previously treated. Venetoclax will be given to a dose of 400 milligrams, so half the dose of what we use in the clinical trial, so hopefully less neutropenia. Ibrutinib will be given at a formal dose of 420 milligrams. The idea behind this combination is not only the fact that clinically speaking, in Waldenstrom's and scientifically speaking, these agents are active, but this combination has also been tried already in CLL and other lymphomas with great benefits and great efficacy. So we are very excited about this treatment option. Now, the design of the study is going to be study Ibrutinib first for about a month. In month number 2, Venetoclax started 100 milligrams per day, which is 1 pill, and then 2 for a week, and then 200 milligrams per day for a week, and then 400 milligrams for the duration of the study, 2 years. And if you can see here at the end, on the right end, there's no arrow, which means both treatments, both Ibrutinib and Venetoclax, will be stopped at that time. So we're aiming on enrolling 50 patients on this study. We do already started accruing. We have about 10 patients enrolled, and they're all in the first month of treatment, so it's very early on. But we are very encouraged by this study, and we're very excited about this study too. And we're trying to get into a VGPR over 40%. We're hoping to see some CRs here, and obviously we will let you guys know, on due time, the results of the preliminary results of this study. So with that, I really want to finish this part of the presentation. And if you have any questions, I remain at your disposal. I'm going to stop sharing my screen now. Thank you very much for your time. Good. So I already see some questions in the chat. So if okay with Paul and everybody, I will probably read them and go from there. I have Dina Kudaski. Hi, Dina. How are you? Where are you? Ah, there you go. Hi. All right. So I have the question here. Question is about immunotherapy in the age of COVID. Any option for home treatments? Yeah. Unfortunately, no. I don't think any intravenous treatments or even injections are being given at home. In Europe, they started doing some studies with Velcade being injected under the skin at home. And there's some data coming out of that. But that's as far as we have gone. I mean, the Europeans tend to be a little bit more, more avant-garde in that specific situation. But at this time, we are not, providing home treatments for immunotherapy, specifically rituximab and ofatumumab and things like that. Now, in the age of COVID, obviously, any treatment increases the potential risk of infections. So we always have to be mindful about that. Having said all that, I think chemotherapy is probably the ones that increases the risk the most, active chemotherapy. I think antibodies do decrease the risk of infections, but at a lower intensity than chemotherapy does. And I think Ibrutinib and medications like Ibrutinib do also affect the immune system, but I think probably at a little lower than antibodies. Obviously, the patients who are not on active treatments are probably at a lower risk of catching the COVID-19. But not at a completely normal level than anybody else without Waldenstrom's, just because of the immune system. So there are potentially different levels. I think the patients who are the mostly affected by this risk will be patients with prior chemotherapy exposure or active chemotherapy exposure, or patients who had transplants, for example, in the past. I think those patients have a much higher risk, obviously, of catching this infection. I have another question from John Burka here. It says, our hematologists in Halifax seem to discourage looking for mutations. They say it doesn't make any significant difference in therapy. Should we encourage them to do this test? Not sure it's a matter of cost. It is a matter of cost, for sure. I mean, that is the matter. Now, I think, if we want to be, the thing is, being in a research center is different than being in the community. And the reason we genotype everybody is because we can. We have the resources to do it. We have the technology to do it. We have Trion's laboratory, which is second to none in terms of the quality of the genomic testing that we could potentially do. But I understand how in the community setting, how do we use this in a more cost-effective manner? So I understand that. So what I would say is, if we are in a situation in which, we need to choose who to test, I think one of the people that we might need to test for MYD88 are the patients in whom the diagnosis is not certain, right? A group of patients in whom, is it Waldenstrom's, is it marginal zone lymphoma, is it IgM myeloma? How do we differentiate that appropriately? So in that scenario, which is not very common, I would say maybe 10% or 15% of patients, that might be a scenario in which doing a MYD88 mutation testing is important. The other scenario will be if we are thinking that Ibrutinib is the right way to go. In that scenario, knowing the CXER4 mutation testing is the right thing to do. If somebody is going to go into rituximab or bendamustine or bortezomib or any of these regimens, cyclophosphamide, there is no data that CXER4 mutations affect the efficacy of any of those treatments. Actually, there is data suggesting that there's no problem with those treatments. So if somebody's going to get Velcade, I don't think they need to know if they have CXER4 mutation. If somebody's going to get bendamustine, probably they don't need to know if they have CXER4 mutations. But if they're going to get Ibrutinib, maybe in that scenario, knowing if you have the CXER4 mutation is probably the right thing to do. So, trying to be cost effective, right? In the United States, that's a little less of an issue. Only God knows for how long, right? Because the cost is going to be an issue everywhere shortly. So the testing tends to be more spread out, specifically for MYD88 here. CXER4 is still having a little issues, but I understand the reluctance of some clinicians on checking these mutations if they're going to end up giving bendamustine and rituximab to everybody regardless, right? I have another question here. My question is about returning to teaching grade 1 in the fall, full time. I only have one cyclophosphamide in the past. Blood levels, IgG is 6.5, which I'm assuming is 650. IgM is 1.65, which I assume is 1,650. Recommending people to return to work in the COVID time. Yeah, I mean, it's very difficult for me to provide a specific recommendation, even though the numbers are here, because you are not my clinic, my patient formally, and I don't have a license in Canada, so I cannot provide a medical recommendation. My sense is going back is going to represent a risk, and I mean, how much of a risk, how less of a risk, how the different, schools are going to kind of deal with, hybrid models or all online or few, it's just so difficult to see. This approach is going to be more of a personal decision than a medical decision at the end of the day, unfortunately. So I think wearing masks and a face shield and, separating the children and all that is something that could potentially help. But at the end of the day, it will be a risk, right? And I think we all know that. So will the study be open? Betty says, will the study be open to those who have prior treatments at a later date? What study would this be, Betty?
The one with Venetoclax.
The Ibrutinib and Venetoclax?
Yes.
Yeah, so at this time, it is only for frontline. We have agreed with the company that if we are running into a stall in terms of accruing, rate and things like that, we might open it up to other patients who have not been exposed to Ibrutinib or Venetoclax. So they have to be Ibrutinib and Venetoclax naive population. But as it stands today, it's only for treatment naive patients. Wayne has a question here. MYD88 and CXER4 mutation tested via blood or marrow. It can be done in both. In both. I mean, there are techniques to follow, testing in both tissues. The bone marrow tends to be still the preferred source of tissue, just because you have more disease there, and so you're trying to find, an abnormal signal. So it's better to find an abnormal signal when you have more of the material that has the abnormal signal. As you can understand, if we take one tube from the marrow and one tube for blood, you have much more disease in the marrow than in the blood. So it's easier to find the mutations in the marrow than in the blood for that purpose. If patients have never treated, sometimes the blood kind of matches the marrow to some degree. But regardless of that, I think the technologies work better when we're using marrow compared to blood. So for that is that. It says here, on Monday, I had my 8th and last maintenance rituximab. I'm 81. What should I expect next? My oncologist will see me on November 13. So I will not say go. I have no idea if I have a mutation. Do I need to know? At this time, probably not. Probably you do not need to know based on what I'm seeing, because I don't think anybody will give you more than 8, maintenance rituximab infusions. So what the expectations next will be, being seen every 3 months with blood work and monitoring your symptoms and hoping that, whatever response has been achieved will sustain, for the foreseeable future. Matt Seliskar here. Hi, how are you? So it says here, do you know if the daratumumab study will recruit in Canada? Any known risk of neuropathy with daratumumab? I don't think the daratumumab study will be open in Canada. I think it's open currently just in the United States, and it's just a very small group of people. I do not have any data on neuropathy in daratumumab. I do have one case of an IgM MGUS patient who got daratumumab, but that's MGUS patient. It was a very distinct MGUS patient because in the marrow, They didn't find mediated mutation. They actually found cyclin D1, which is more of a marker of IgM myeloma. So it's not the classic IgM MGUS with neuropathy that we tend to see. And that patient seemed to be doing okay. But again, it's one sample size of one person who doesn't meet the most common criteria that most of IgM MGUSs do around here. So that's what I have from that. Betty says here, I have a letter from my doctor saying I'm at high risk and I should not go back to the classroom. Yeah, I mean, sure. I think if your doctor is, you know, is providing that letter, then I think you could use it. You know, feel free to use it. Another question here, is it true for relapsed Waldenström's after chemo that they are more likely to try stem cell? The stem cell approach, and I'm assuming this is autologous stem cell transplant, not allogeneic, meaning your own stem cells, not somebody else's stem cells. Somebody else's stem cells is not something that we really do for Waldenström's. Autologous transplants can be done sometimes in situations in which a patient is young and a patient has basically not responded to most of the you know, standard treatments like try bendamustine and fail really quickly, try Velcade, fail really quickly, rituximab. You know, in that scenario, maybe in the patient is really younger than 60, we could potentially consider autologous transplants. But the large majority of the patients diagnosed in their 60s or 70s, very likely or very unlikely will, you know, get to a point in which they need to be transplanted. Now that could be very different from place to place. If you are, for example, in a more restricted place in terms of what treatment options you can have, then they might opt to do the transplants earlier on, right? And the reason for that is because they have fewer options. They might not be able to afford Ibrutinib. They might not be able to afford a Calabrutinib or Zanubrutinib or Venetoclax, or, you know, or even carfilzomib or ixazomib. So that leaves you cyclophosphamide, bendamustine, and Velcade, and that's it. You're done with that, right? So if you're in a situation in which your options are restricted, then, you know, maybe at that moment thinking about autologous transplant might not be a bad idea. But in the era in which we have so many other Btk inhibitors and so many other BCL2 inhibitors, assuming that you can access them, then transplants, autologous transplants are being moved a little bit more and more and down the road. Now there's a complete new cadre of immunotherapies that I have not talked about because there's no data on Waldenström's, but very likely we will be talking about in the next year or so. One of them is called the antibody drug conjugates, in which they actually put microdoses of chemotherapy in antibodies. There's one that just got approved for myeloma called belantamab, which I think we might be able to study in Waldenström's. There's others called BiTEs, which is essentially an antibody that is half B cell, half T cell. So when it's given, basically attracts T cells close to the B cells so the T cells can kill the B cells. So those are, a number of them are being developed now for for myeloma, and maybe they will spill out into Waldenström's. And obviously CAR T cells. You know, CAR T cells are you know, doing wonders in lymphoma. They seem to be doing a very good job in myeloma as well. So it wouldn't be too far until we start developing a Waldenström CAR T cell program at Dana-Farber. That's one of my goals for the next year, with the addition of the new physician that is going to be joining the group to expand our clinical efforts. So yeah, a bunch of stuff coming up. So so if you responded fairly well to Benda-R for initial treatment, would be used as a second time after progression. Oh, and Moffat, where are you? I didn't see you there. And oh, there you go. Yeah, I see you now. Hi.
Hello, Dr.
I had to scroll down the road. Yeah. So it could potentially be used. The problem is that the more chemotherapy exposure patients have, then the higher the risk of developing myeloid neoplasms is, you know, specifically myeloid leukemias and things like that. So that's why we try to minimize the exposure to bendamustine. Typically, the Germans use 6 cycles. So we do 4, and only if it's necessary, we do 6, but there's a group of people who just get 4. So if you just got 4, then, you know, you can use 4 later on, and I would not feel too concerned about it. But again, I have seen patients who have gotten bendamustine and then get cyclophosphamide later on, or get cyclophosphamide first and then bendamustine later on. So I think it will be a reasonable option if there's no other options, right? But again, we have other treatment options too that could potentially be beneficial. I have another patient here says, I have had an enlarged spleen for over 20 years, initially diagnosed with splenic marginal zone lymphoma and later Waldenstrom's when the IgM started rising. BR therapy worked nicely, except that I always rigor with rituximab. Yeah, welcome to the Waldenstrom world. The spleen has never reduced in size. I'm on one shot waiting. Do I actually have Waldenstrom's or splenic marginal zone lymphoma? The hematologist said I probably will get Ibrutinib if the IgM goes up again. Does that sound right? Yeah, I mean, just by looking at this, it's very difficult to say exactly what's going on. This is the type of situations in which we get more samples from patients. We try to do some genomic testing. There are some mutations that are seen more commonly in marginal zone lymphoma than in Waldenstrom's. If the spleen is the one that is enlarged, we need to make an assumption that is a center of disease. Having said that, if everything responded very well, but the spleen did not reduce in size, then it is a little bit hard to say if it's really disease or not. Now, obviously, you would have to see how enlarged it is, right? Because sometimes some radiologists or some doctors say, oh, this is a very large spleen and it's not really that large, right? So 15 centimeters is what is considered enlarged. But we have seen patients with spleens up 20, 25, 30, 35 centimeters, right? The normal is between 8 and 12. So anything over 15 is considered enlarged. So again, some people call it enlarged when there's only 13 centimeters, for example, and maybe that is not so enlarged at the end of the day. So these type of, I think at this time, it doesn't really matter if this patient has Waldenstrom's splenic marginal zone. Now, if the disease recurs and the patient needs to be treated, maybe at that time would be a good idea to try to differentiate, because the same advances that are happening in Waldenstrom's are also happening in marginal zone lymphoma. And if there's a doubt, Ibrutinib, for example, works much better for Waldenstrom's than what it does for marginal zone lymphoma. The efficacy in marginal zone lymphoma is like 40, 45%. It's not really great compared to Waldenstrom's, which is like over 90%. So knowing the actual diagnosis will be important. But probably something that we need to deal with at the time in which disease comes back. It says here 12 centimeters outside of the rib cage. So that means 12 centimeters from the rib cage down. That's very, 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 very large. That we almost never see that with Waldenstrom's. If this is truly associated with the disease, more likely, in my mind, splenic marginal zone lymphoma. Marginal zone lymphoma is the lymphoma that can have IgM secretion the most. We just submitted a paper, an abstract to ASH, in which about 1 in 3 patients with marginal zone lymphoma actually have IgM secretion. So it is very common. It's very common to have IgM secretion in marginal zone lymphoma. So we need to be very careful when we label patients. And again, the diagnosis sometimes is not easy, and we do our best. And even with our best efforts, we are not able to differentiate these conditions appropriately. But just the size, if that's truly the size of the spleen, I think in my mind that will speak a little less in favor of Waldenstrom's, a little more in favor of splenic marginal zone. Good. So Betty says that maybe your doctor can chat with me. I'm happy to. My email address was there. You can provide it to your doctor. I'm happy to talk to your doctor if necessary.
Are there any other questions that people have? Dr. Castillo, it was so wonderful of you to give up time, and 36 Canadian or 36 people on the call. We're very pleased with that. And it's wonderful to see you. You look great. How's your family?
Well, everybody's well, thankfully. I think the neighborhood that we are part of hasn't really been hit much by the virus. I'm going to work, I would say probably 3 times a week. But again, there's a lot of safety measures being taken at Dana-Farber to protect the patients and protect the staff from infections. So, so far, I think Massachusetts have been able to weather, the COVID storm relatively well. And we're waiting for that resurgence because we just opened, we're opening the States. So we're waiting for that resurgence. But it seems to me that people have been very careful, and so far we haven't seen that as a problem. So I hope everybody's well over there too. I know that other places are not doing so well, so our prayers to them.
I have one question,
Yes,
Dr. Castillo, is can Canadians enroll in, like you say, Dana-Farber has a study. Can Canadians come down and enroll in those or not?
Yeah, so I mean, right now with the COVID-19, a bunch of crossing the border is a little challenging, right? In theory, we have a number of Canadian patients who have come to participate in clinical trials. I mean, we have at least 2 or 3 Canadians that participate in the Ibrutinib relapse study, which is the main study. The downside is that a patient would need to have paid out of pocket essentially. So the medications are given for free, right? So that's not an expense, but the travel and the housing, the lodging if you need to stay overnight, and the payment of the labs and the image that is considered standard of care, then that will need to be absorbed by the patient. So it's much more expensive for a Canadian patient to participate in a clinical trial in the United States because of that. Now, we do have a couple of patients from other outside of in Europe and Asia who actually have an international insurance that kind of help in that scenario, but again, no, not something that most people do have or know what it is all about. We do have patients that came to participate from Europe in clinical trials as well. And again, same thing. I mean, medications are given, free of charge because that's the deal. But again, the travel and the lodging and standard of care labs and images need to be paid for by the participants.
There are a couple more questions that have just got popped in.
Yeah, so have here no new cases of COVID in Nova Scotia in over a week, thankfully. Do you have any info related to COVID in Waldenstrom's? Not a lot. Thank you for the question. Not a lot. I think about a dozen of our patients have been infected. And again, that doesn't count. It's not a systematic review of our database by no means. It's just what we know, what get reported to us, right? So probably about a dozen and a half of patients got infected with COVID-19 with Waldenstrom, some of them on Ibrutinib, some of them off Ibrutinib. The large majority have done well. We have only one case that patient needed to be hospitalized, but the large majority of patients have, they stayed at home, they weathered the symptoms there, and then, they improved. So not a lot of data there. We're actually collecting actively data from the United States and other countries. So we'll probably present something later on, but we don't have a lot of data at this time.
We have been, on behalf of Dana-Farber, trying to find out if there's any Canadian WMers with COVID. And so far, luckily, there haven't been any. So we've not passed that, but that's possible.
Thank you, Paul, for that, because I mean, that's the only way to understand how things are going, just looking for people who are willing to provide their data. I have a question here. Is the relation between a weakened immune system and the vigor of the cytokine storm? That's something we don't know. We don't know the answer to that. And the reason we don't know is because we do have elderly patients who are sick, who get infected, and they don't have major problems. And we have younger people with no previous exposure to anything, normal immune systems, who then develop a very bad case and die from this infection. So, I think there is not one thing that we can categorically say, oh, these patients will do worse 100% of the times or do well 100% of the times. Even having diabetes and having hypertension, I mean, that increases the risk of having a bad reaction to COVID-19, but that doesn't mean that all the diabetics who get COVID-19 will die. I don't think that's something that we can look at it from that perspective. So instead of looking at a weakened immune system, the way I look at it is either an optimal or a suboptimal immune response, which is not the same thing. You can have a weakened immune system and then develop an optimal immune response to the infection. While you can have a great or normal immune system and then not have a suboptimal response to the infection. So it's a little more technical than I would like the answer to have been. But yeah, I mean, I think overall, you know, the chances of getting infected are higher in patients with active lymphoma, much higher in patients on active treatment, and much higher in patients with active chemotherapy treatment, for example. But from there, for me to guarantee that because somebody got it, is definitely going to do worse. You know, I can assume that yes. I mean, if you are in active treatment, if you got it, then probably you are at a higher risk of having a bad outcome. But that doesn't mean that you will have a bad outcome for sure. But the opposite is also true. You know, the fact that you're doing just fine and doing well and your immune system is as good as it could be, that doesn't mean that if you get it, you're going to be for sure going to do fine. I mean, there's always a risk that things might not go well. And that's still, you know, a very, I would say, unanswered question in terms of what is it that actually drives the bad outcomes in this disease.
Betty, I don't know if you have anything else, but
There's one more question there. Oh, no, is that?
just a comment.
So
Okay, just a comment. Okay. No, I just, again, want to really thank you, Dr. Castillo, for joining us. I know that you have a busy schedule, so we really appreciate you taking time for us today. And
sure.
I really think it's great that you are available for second opinions for Canadians. So, yeah, it's I find it really encouraging to hear about all the new treatments that are coming down the pike, and I think we should all be really encouraged by, yeah, lots of opportunities for newer treatments and hope. That's what I hear, lots of hope.
Right.
Right.
So thank you again. And
Right. Thank you, everybody, for your time. And, you know, if there's anything else that you think I can do for you, let me know. As Betty said, I'm always happy to help. There are different ways of doing this. So if you want, one way to do this will be to have your doctor reach out to me for questions. And that will be a very informal way. Your doctor has specific questions, which I answer. That's one way of helping. The other way is if you want to have a formal consultation, there are two ways of doing it. There's electronic medical record review, which you do through a second opinion service through the Dana-Farber. And you just put Dana-Farber second opinions, and that's an electronic review. I get all your records, I review them, and I provide a written report. Or you can do a face-to-face, which I also review all the records, and then I have a formal interview with the patient. So that can also be done through Dana-Farber. So again, different ways in which we could potentially help. Unfortunately, you know, if you email me directly and you're not my patient, you know, I might not provide you with formal recommendations. That wouldn't be fair. But if we do it through the, you know, routine formal channels, I think that would be the best way to go.
okay, well, thank you again. And just a reminder to everyone that our next meeting, national meeting, is October the 21st.
All right. Thank you very much, everybody. Have a nice rest of the week.
Thank you, Dr. Castillo.
Thank you.
Thank you so much.
Thank you.
Thank you. Thanks.
You will.
Bye-bye.
Thank you very much. Bye-bye.